And I want to thank you all for being here and for your attention for the next 30 or so minutes. I'm going to review what exactly we're talking about when we talk about psychedelic therapy, and also dig into some details of the study that this was a part of, which has recently completed enrollment, but we still have about a month's worth of study procedures before all the primary endpoints are collected. Before continuing, of course, I should disclose that I've had scientific advisory relationships with a few companies within this space. Nothing that I've been involved with in terms of these companies is kind of impacting what I'm going to tell you about, nor is anything in this study going to necessarily directly impact these companies. And hopefully by the end of this talk, you'll have a better purchase on describing the therapeutic approach currently used with psilocybin, and you'll be hopefully able to better summarize some recent findings regarding the potential effects of psilocybin to treat patients with mood and substance use disorders. But I'd like to start at the beginning, just so that we level set and so that we all understand from the ground up what are psychedelic drugs. If you look in the dictionary, you're likely to find a definition that includes phrases and clauses such as sensory perception, big feelings, hallucinations, and these are of interest and they often occur during psychedelic experiences, but I believe these are not quite capturing what was intended by the individual who coined this phrase, psyche meaning mind, and delos meaning manifest or soul revealing. This term was coined by Humphrey Osmond, who was a British psychiatrist expatriated to Canada, and he was one of the first two people to use LSD within a clinical setting. And he himself, he self-administered LSD as well as psilocybin mushrooms, mescaline, and other psychedelic-like compounds, partly to understand from his own first-person perspective, what does this experience feel like, and can I use that information to understand how best to use the compounds in the clinic. He also shared psychedelics with his friends, including Aldous Huxley, who famously penned a book called The Doors of Perception, and if you have any interest, I'd recommend you read that just to get Aldous Huxley's perspective. But really, Humphrey Osmond thought that psychedelics did something to reveal one's own mind or soul to the individual in a way that a person didn't normally have access during normal waking consciousness, and hence the term psychedelic. If you come away from this talk with nothing else, please take the perspective of if someone says psychedelic or psychedelic therapy, ask which one, because this is a term that is being broadly applied to a wide range of pharmacological compounds and classes. We, of course, have psilocybin, the active component in psychoactive mushrooms, hundreds of species of psychoactive mushroom. We have mescaline, which is found in psychoactive cacti. We have synthetic compounds like LSD. People are also calling ketamine, the dissociative anesthetic, dextromethorphan, a common cough syrup, which actually has a somewhat similar molecular pathway to ketamine. Salvinorin A, which is a little more esoteric, as well as ibogaine, MDMA, which is a research chemical, and of course cannabinoids. I read a tweet a month or two ago that suggested that trazodone should be called a psychedelic, and that's just kind of putting a fine point on the fact that these are all very different drugs with differing molecular pharmacology, different abuse liability to the degree that any of them have a therapeutic model built up around them. They differ in subtle or important ways in the therapeutic model. So ask which one. And we're going to focus in on classic psychedelics. These all share the property of being agonists or partial agonists at the serotonin 2A receptor. But even within the classic psychedelic umbrella are multiple pharmacological classes, tryptamines that are structurally very similar to serotonin, phenethylamines, ergotamines, and others. And of course, these chemical structures on the top right, we have serotonin, and then we're comparing all of them in structure. You can see an amine group at least or more in all of these structures. They all share the ignoble property of being Schedule I compounds, which means as far as the DEA is concerned, they have no known medical use, high toxicity and abuse liability. But they also are all, at least psilocybin is in multiple now phase 3 registration trials for the treatment of depression and treatment-resistant depression. And full disclosure, our center at Hopkins is one of the clinical trial sites for one of these registration trials. We're going to focus in on psilocybin for the rest of the talk because that's where the lion's share of therapeutic evidence and safety evidence to date in the modern era is. We can talk a little bit about now what are the risks of psilocybin, because this will kind of inform and frame what psilocybin therapy is. There are physiological risks that are well known that really mostly are contained within increased stress in the cardiac system. Psilocybin specifically has a dose-dependent, modest, but reliable increase in heart rate and blood pressure. And really that's it. Many different animal systems have been studied for toxicology, and thousands of times greater doses than are equivalent to what we administer clinically have been administered with no other known physiological effects or toxicity in any organ system. We can ask the question of whether psilocybin or related compounds have abuse liability, and briefly, they don't show up the same way that classic drugs of misuse show up. We have self-administration assays wherein if you can train an animal to self-administer a compound, it may have increased abuse liability. You have to bend over backwards to trick rodents into self-administering classic psychedelics to any degree close to drugs with a known pattern of misuse. We have substitution assays to the degree if you can train an animal to self-administer a known compound that's misused, and then you can test it with a novel compound, and if the novel compound will substitute, or if the animal behaves in the same way as it did with a novel compound to the way that it did with the known compound, you can say they may have similar abuse liability, and psychedelics don't substitute for any other compounds of known misuse. Drugs of misuse typically engender craving and withdrawal syndromes, which these don't really show up with psychedelics, and they don't drive compulsive drug seeking nearly to the degree that any typical drug of misuse does. Really, the risks of psychedelics are primarily psychological. We believe there may be an inherent vulnerability of people who have a personal or family history of psychosis. People can have challenging experiences, colloquially known as bad trips. These can manifest as overwhelming fear, grief, feeling of physiological distress, though not really clearly identified outside of something like a panic attack. People say they feel like they're going insane, or they feel like they're paranoid, or maybe they feel like they're dying. On average, roughly 20 to 30% of people who receive a very high therapeutic dose will have an experience in this scope at least at one point during their psychedelic experience. Typically they don't last very long, but sometimes they last the entire experience. But meaningfully, these are not meaningfully related at this time, or we haven't identified a meaningful relationship between a challenging experience and negative therapeutic outcomes. Oftentimes people report a very challenging experience that itself was therapeutic. I have to highlight risks in uncontrolled settings. We've done multiple internet surveys, large sample surveys. Many thousands of people have completed the surveys and have indicated essentially, a series of indicators of risk in uncontrolled settings. In one of our surveys of roughly 2,000 people, 11% said they put themselves or others at risk of physical harm during their challenging experience. Nearly 8% sought treatment for enduring psychological symptoms that they attribute to the challenging experience, and nearly 3% sought and received immediate emergency medical care during the experience. These are not base rates of challenging experiences in the population of people who have been exposed to psychedelics, but rather the rates of these occurrences in people who have said they've had very challenging experiences and related to their challenging experiences. But clearly there's a signal for risk in uncontrolled settings. And because of all these reasons, we take a very careful approach to delivering psychedelics in a research environment. And we believe this is likely to strongly inform future clinical care if that's ever to happen, but we're very careful to screen out those with cardiovascular risk, not because we know there's a specific cardiovascular toxicity, but when you stress the cardiac system, you can uncover bad things, and we don't want to do that. We also exclude those who are at risk of psychosis with personal or family history of psychosis, and there are a certain range of indications that may or may not be contraindicated with psychedelics. But after very careful screening, when people are enrolled into a study, they undergo, in therapeutic trials, typically 6 to 8 hours of preparation sessions. These include rapport building, unstructured psychotherapy, and also psychoeducation about the potential effects of psychedelic drugs. And after the screening and preparation, participants are then asked to engage in one or more drug administration sessions. People arrive early in the morning, do some final screening, and then are administered a capsule, and they're accompanied by 2 trained study team members, at least one of whom is a independently licensed mental health practitioner. These sessions typically last about 6 to 8 hours, and the primary acute effects of psilocybin typically resolve within that time. Participants are then sent home in the care of a loved one or a friend, asked to come back the next day and tell us what happened. Write a report. Typically, it can be a couple bullet points. It can be War and Peace. Whatever you experienced, write it down so we can talk about it. And participants then undergo, what I like to refer to as aftercare and follow-up therapy for days, weeks, and sometimes months after the experience. So when we talk about psychedelic therapy, this is what we're talking about, this entire package. And you'll notice there's an awful lot of extra pharmacological machinery and mechanism here, which I think is important, and which I think we all think at the very least provides some level of harm reduction and safety for patients, if not also, important therapeutic value. There was an awful lot of research conducted with psychedelics between the 50s and 1971 when the Controlled Substances Act was passed. There were thousands of papers written, tens and tens of thousands of people administered LSD and other psychedelic drugs in a clinical or research setting and other settings. On the left we have Dr. Albert Hofmann, who first synthesized LSD in 1938, later surreptitiously, as the story goes, discovered the effects of LSD. He later isolated psilocybin from psilocybe mushrooms in 1958. He's an important figure, but this kind of gives you a timeline of recent, timeline of Western approach to psychedelics, including psilocybin. And I wanted to highlight one of the last studies to be published from that era with our own Lee McCabe, who's here in the audience, and thank you, Lee, for your work. He published not only one of the last trials of that era, but also one of the most rigorous trials demonstrating the potential of LSD to help to treat patients with opioid use disorder. From that point into the current era, psychedelic science with humans lay dormant until about 2006, when Roland Griffiths published the first healthy participant trial with psilocybin in the modern era, which is credited with kind of kicking off the psychedelic renaissance. A few years after that, we published the first randomized control trial in patients with major depressive disorder, demonstrating at first enduring therapeutic response in patients for 6 months and then 1 year, and we just maybe a week or two ago, published a follow-up study demonstrating that for at least 5 years after treatment with 2 doses of psilocybin, separated by approximately a week or more, over 50% of the patients in this study were in remission, and roughly, 67% were in remission at 5 years, and roughly the same amount still showed an enduring therapeutic response, which is at least a 50% reduction in depression severity from baseline. And on the left, we have the beautiful averages with showing actually, pretty remarkable effect sizes of Cohen's d well over 2. On the right, you see the reality, which is, this is a spaghetti plot showing 1 line per individual out of the 24 individuals in this study and the 18 who were able to participate in the 5-year follow-up. And we see that, indeed, many people did have a precipitous drop in depression severity that was sustained, but some people also had a recurrence of depression, and notably, we have the purple line up top and the dotted yellow line in the middle, tan line in the middle, of people who you could consider as non-responders. Clearly, this doesn't work for everyone. Clearly, there's work to be done to understand from a more precise and precision medicine perspective how this all works and who we can help. This study was followed up by a much larger randomized control trial comparing psilocybin within that entire package that I showed you to niacin within that, a very high dose of niacin within that entire package. This is a historical control that was used as a control condition in the very first psilocybin study published in the 60s. I think it's an awful control because a very high dose of niacin will give you flushing and make you feel awful for a short period of time, but by the end of 8 hours, everybody knows who did and did not receive psilocybin, yet this is what was used. It was an attempt to have a psychoactive substance that made you feel a certain way, but it didn't blind anybody. But we still see a significant and substantial reduction in depression severity after psilocybin administration that lasted for at least 6 weeks. There was an additional randomized control trial in a slightly larger number of participants who had specifically treatment-resistant depression. Here, instead of another psychoactive substance, lower doses of psilocybin were administered, and 25 milligrams, which is the canonical therapeutic dose now, was shown superior to 10 and 1 milligrams of psilocybin. Psilocybin was also compared to escitalopram. Participants were enrolled in a study and either given daily placebo pills for 6 weeks and 2 doses of psilocybin, or 2 doses of placebo within the therapeutic context and then daily escitalopram. And this I interpret as at least a non-inferiority outcome. The QIDS self-reported inventory, 16 items, was the pre-registered primary outcome measure, primary endpoint, and this failed significance, but there were a number of additional measures that did favor psilocybin over escitalopram. I said that there were thousands of studies published in the previous era. The vast majority don't meet modern criteria for rigor or reproducibility in science. Yet, in 2012, colleagues across the pond, Krebs and Johansson, scoured through the literature, found 6 studies which they felt did meet some definition of rigor and reproducibility, mostly in terms of having some kind of comparator condition and describing it well enough to understand it. And the comparators here included LSD compared to an inactive placebo, or LSD compared to treatment as usual, or something like that nature. But across these 6 studies with a grab bag of control conditions, their meta-analysis indicated favoring LSD over the various control conditions for the treatment of alcohol use disorder. And Humphrey Osmond, who I referred to in the beginning, claimed between 54 and 60 to have treated thousands of patients with LSD, and he also claimed, nearly 50% of them were abstinent alcohol at least 1 year post-treatment, which even now would be a remarkable claim, but back then was even more remarkable. So following up on that, our colleagues in New York, led by Michael Bogenschutz, published an early pilot study, an open-label pilot study, followed by a randomized control trial using a very high dose of diphenhydramine as a comparator to psilocybin within that therapeutic package I told you. And in both cases, he showed a significant reduction in drinking days and heavy drinking days that lasted again for, in the control trial, at least 36 weeks. So this all was kind of a rationale for me to say, okay, we have growing evidence that psilocybin may be helpful in treating patients with mood disorders, and we have growing evidence that has a historical precedent that psilocybin may be helpful in treating patients with alcohol use disorder. And of course, I didn't reference the great work that was done here with tobacco use disorder by Matt Johnson, and that's being done currently by others around the country and around the world in additional substance use disorder populations. So we planned this 90-person study in patients with major depressive disorder and alcohol use disorder. Of course, briefly, these are 2 disorders that co-occur more as a rule rather than an exception in real life with people who are out in the world suffering. They reinforce each other. People who have the co-occurring disorders are less likely to seek treatment. If they seek treatment, they're less likely to adhere to treatment. If they adhere to treatment, they're less likely to respond. And if they respond, they're more likely to remit. And the cycle continues. And so this is a population with great need. And going into this, there were a few concerns that, well, maybe actually that's going to be a huge challenge. Maybe it'll be more resistant to psilocybin therapy. We will see. So this is the design of the study, and I hate to kind of hurt your eyes with this. Let me walk you through it in big steps. So we have enrollment, where there's a blinded clinician-rated depression severity assessment and a 90-day assessment of alcohol use, followed by prep sessions. And then there's an experimental phase during which people are randomized to receive a high active dose of psilocybin, 25 milligrams oral psilocybin, or an inactive placebo. And then we follow people for 3 months, not only to get an assessment, another blinded clinician assessment of depression severity at 1 month post-treatment, but also to get an additional 3 months of alcohol use to see whether, and that's really one of the minimum lengths of time at which you can begin to believe that a person's drinking may have changed in an important way. So we have this experimental phase, which is blinded, and it's still blinded. And then after that 3-month period, everyone is crossed over to an open label drug administration session with 25 milligrams psilocybin. We repeat that monitoring period. And also you'll see below PrEP 4 and then two visits post-session, we have a motivational interviewing intervention, a brief MI intervention for alcohol use. And also important for the next slides I'll show, motivational interviewing, if you're not familiar, does not set, it involves psychoeducation as well as an interaction with the patient. You do not set the goals for the patient, rather the patient sets goals for themselves. And in this study, I'd say the majority of patients in the study didn't set a goal of abstinence, rather, whatever they defined as a healthy relationship with alcohol. And so we're not going to show you the experimental phase. It's still unblinded. Actually, that N is 87. Pardon the error there. But we will look at comparison of pre-treatment to 1 month and 3 month post-open label in the first roughly 30 people who completed the trial at that point. And we see these are grid Hamilton Depression Rating Scale scores. Above the green line is mild, above the blue line is moderate, and above the red line is severe depression severity. And we can see that patients in this study were moderately to severely depressed upon entrance into the trial, and we see that nearly all of them are mildly, if not in remission, at 1 month after the open label session. We also have heavy drinking days, which precipitously drops from a pretreatment baseline to 90 days after the open label trial, and we see days abstinent more or less going up in the majority of patients. And again, these are more or less consistent with people's goals, their stated goals, not necessarily of abstinence. Some do have an abstinence goal, but of reducing their drinking. And in addition, at these time points, we collected liver function tests, a variety of them that are sensitive to varying levels of alcohol use. We have AST over ALT, we have percent CDT, and we have GGT. And these are actually sensitive to different time periods of drinking, over a week or two or a month or 3 months. And we were a little worried once we began, looking at the blood tests coming in, because importantly, we are only enrolling patients who we don't believe have particular risk for medically complicated withdrawal from alcohol use. We're not resourced to manage those patients. They may represent a different population that definitely deserves attention, but patients had to, on average, have at least 1 non-drinking day per week in the past 90 days, also have 2 heavy drinking days per month in the past 90 days. So we're admittedly getting a population that is moderately, using alcohol, but not the most severe cases. And so the liver function tests all usually come in pretty low, but among the few patients who had high liver function tests, at least GGT, which is sensitive to longer periods of drinking, those are coming down, and so enough that this is a marginally significant effect at this point. So caveats abound. Of course, we don't know what the unblinded placebo control is going to tell us. It may be that there's something unique about the study, that everyone is getting better at an equal rate, which would be good for those patients, maybe not helpful for the use of psilocybin in this population. I hope to tell you within the next 6 months what the answer to that is. But there are lots of kind of considerations that can go from here. A few design issues that we had to grapple with one was the sense that patients who are drinking too much need more. They need more antibiotics. They may need a higher dose of pain medications. And it was actually pretty elegantly demonstrated in Michael Bogenschut's study at NYU, his randomized control trial with alcohol use disorder. He built in a dose escalation such that if people did not score above a certain threshold in the intensity of their subjective effects during the psychedelic experience, they would be escalated from 25 milligrams of psilocybin, which is the canonical dose for depression, up to 40 milligrams. And most patients in the study met that criterion, escalated, and he showed in a secondary analysis that it was actually that higher dose that much more strongly drove therapeutic outcomes in the trial. So in this population, are we giving people a large enough dose at 25 milligrams? We said we're going to try 25 milligrams. I honestly conceived of this study as a study for patients with depression who also drink a little too much. And I thought we will take what we're doing for depression and study that in this population as is, without asking too many more methodological questions. So we may be undermining our potential therapeutic effects by underdosing patients. That's a possibility. Another possibility is that patients who are being maintained on SSRIs, there's a theoretical rationale that patients being maintained on SSRIs may have a blunted response to psychedelic drugs and psilocybin specifically, and therefore either they may need a higher dose of the psychedelic to overcome that, or we may need to wean them off of SSRIs. And there was never really a concern that co-administration of psilocybin with SSRIs presented any particular physiological or toxicology or mental health risk, but rather this kind of undermining psilocybin effects. Halfway through the study, there were two studies that were published that suggested, in fact, co-administering these things both in healthy people and in patients with depression wasn't an issue, didn't reduce therapeutic outcomes, didn't markedly reduce anything except slightly reduced the occurrence and the intensity of challenging experience. Okay, that doesn't sound too bad. So halfway through the study, we began enrolling patients who were maintained on SSRIs, and so half of our sample now includes this. Within the context of all of this, we administered a high dose of psilocybin along with an inactive placebo, and one of the really vexing methodological problems in the field is, well, I alluded to it with niacin. If people know what condition they're in at the end of the day, if the study team knows what condition a person's in at the end of the day, we can't really call these double-blind. We can't really call these blinded. People, if they're functionally unblinded, then we get into a thorny issue of whether we can really dissociate the fact that someone felt something to whatever degree they felt it with, the kind of inflation of expectancy. And so going into this trial, admittedly, using an inactive placebo control offers its own methodological limitations, but I can say anecdotally, at least to this point, there are, and tell me if you disagree, Darrett's one of our therapists in the study, some participants were not sure. Some participants, they're not sure. And it's only when we get to that second open label session that a participant in the study team knows for that individual, well, no, how does this compare to the other? And I can tell you, and sometimes that's unclear too. People having actually underwhelming experiences sometimes. We don't know if that's because they have such an overwhelming expectancy that upon receiving placebo, they're not making it up in their heads, but they're generating, and you can internally generate all sorts of experiences. Or whether a person's alcohol use level is kind of blunting the effects of psilocybin, or whether the SSRIs, in particular, we have two patients who experienced no subjective effects during the known open label sessions. They were taking venlafaxine. They're the two patients in the study who were taking venlafaxine, at least to the point that we collected this data point. There are lots of interesting questions to come up with here. Needless to say, people who are having underwhelming experiences, many of them are also yielding therapeutic effects. I'm on team subjective experience. I think there's something unique about the psychological experience people encounter during the experimental drug administration sessions that ends up feeding or becoming part of their healing story. I am willing to be persuaded by data. And I think this, when we unblind these data, we're going to have something really interesting to look at and to ponder. And I'm going to do a speed run through the final few slides, and I apologize. If any of this is of interest, please ask questions about it, but I'll leave that up to you. The field has a growing number of theories and models that are attempting to explain why and how all of this occurs. Psychedelics have specific and demonstrable effects on more objective behaviors that fall into psychological, cognitive, and neural kind of buckets and circuits and processes. And we're demonstrating that psychedelics may lead to acute impairment in specific psychological domains, and then post-acute enhancement in some of those, including cognitive flexibility, or the flexibility with which you think of yourself and your place in the world. And I think that our patient's story here kind of reflects a bit upon that. We can get into that. Psychedelics also have effects on memory. They may have inflammatory and plastic effects. It's possible that psychedelics may affect sleep, microbiome, response to stress. And so this is some of the evidence that psychedelics may have neuroplastic and cognitive effects. We're following up with as many patients as possible with functional MRI measures as well as spectroscopic measures, and looking for functional and structural changes in the brain, off-magnet batteries of tasks to really parse apart cognitive domains that may be affected acutely and post-acutely. What changes, how does it change, and does it relate to the therapeutic outcome? And we're looking at sleep, we're looking at electrophysiology, we're looking at the gut microbiome. So hopefully we're taking really a shotgun approach, not because we don't know what we're looking for, but because there are so many potential vectors of mechanistic action here that we we want to know the whole picture. And also a number of colleagues now here at Hopkins in neuroscience and psychiatry, including Kelly Tomashiro and many others, are following up with animal studies to kind of to trace this in a translational fashion. Just a final note, I mentioned that psilocybin is now being tested in multiple phase 3 registration trials. They should be pivotal trials. There were additional trials earlier on for multiple different manifestations of substance use disorder, as well as other psychiatric disorders and neurological disorders. There are lots of other compounds that are in earlier phases of development. There are an exhausting number of indications being tested. I just want to say that I don't think that it's likely psychedelics will be clinically and therapeutically useful in all of these things. We can't treat psychedelics like a panacea and be skeptical of anybody who does. But it is possible that psychedelics are tapping into some transdiagnostic mechanisms that do explain in a reasonable way why psychedelics may be effective across certain indications in which we might not necessarily expect them to be. And I want to just end by thanking all of the really amazing people that I have the privilege of working with in the center, and without whom none of this would be possible. And I'm happy to take any questions you have.
Thank you, Dr. Barrett. That was fascinating. Boy, those results are impressive. They really look quite impressive. Let me ask you this. You talked about controlled conditions and blinding, and our patient today ended on the point that he feels like the progress that he made really hinged so much on this psychological support / psychotherapy before and after. And I know that there's been a little bit of controversy in the field, a little debate in the field about how essential that actually is, and not everybody agrees. What's your current feeling about that, and what's the state of the data in that area?
Thanks. I'll kind of augment that by acknowledging that there are a number of drug companies now who are trying to develop novel compounds that have some of the neuroplastic effects of psychedelics, but maybe none of the subjective effects, or a muted version, or a time-delayed version, or kind of modifying the subjective effects of psychedelic drugs. There's some correlational data in the field that seems to be somewhat reliable across many studies, not all of them, that suggests that the magnitude of subjective effects of psychedelics do have a relationship with therapeutic outcomes. And some of the debates in the field, I have to admit, I feel like the positions and the arguments that we don't need the psychedelic effects are theoretical and speculative rather than really soundly established within data that we've observed in humans. Having said that, I think there's a strong rationale for trying to identify drugs that are mechanistically similar yet don't have the subjective effects. I challenged someone at an ACMP meeting a couple of years ago who had a whole panel discussion around this, and I said, aren't you engineering out the kind of really active ingredient? And he said, well, even if we can find compounds that are a quarter as effective as psychedelics, if they end up being as effective as we think they will be, even if we find less effective compounds that are not psychoactive, that will still be useful and helpful for the wide range of people who may not qualify for a psychedelic clinical trial, or who may not be able to afford what admittedly involves an awful lot of professional effort and is likely to be very expensive. I think the weight of evidence behind the relationship between the subjective effects and the clinical outcomes is the strongest in this debate. But I'm willing to be, we're waiting for the clinical trial with the non-psychedelic psychedelic that then brings data to this argument. And until we do that, I will speculate that the data that I have are stronger than the arguments that people have.
Thank you. Other folks have questions? Dr. Bray.
Great question, and not in a clinical population yet. But there are colleagues at the University of Wisconsin in Madison who are administering a psychoactive dose of a psychedelic and then following up once the subjective effects have kind of had their onset with a high dose of benzodiazepine, high enough to cause amnesia, but not high enough to cause sedation. And they've found the sweet spot, and they have a few patients. They're healthy people, they're not patients who've been treated. So the outcome so far, the kind of preliminary results from that suggest that, in fact, you can block memory for the experience, not necessarily blocking the experience itself, and possibly in healthy people, they're not observing long-term kind of therapeutic outcomes. Yet therapeutic-like because they're not patients, and it can be difficult to really convincingly translate that, but I think they're onto something. There's also been a study published at Stanford of patients who were depressed and then kind of going into surgery for a reason other than the depression, and they were enrolled in a trial in which they were told, listen, while you're undergoing general anesthesia with either propofol or I think one of the fluorines, possibly, but while you're under, we will give you an injection of ketamine or we'll give you a saline injection, and then afterwards we'll ask you how you feel. And this is being kind of trotted out as kind of proof that the therapeutic effects of ketamine are reliant upon subjective effects, and the argument of some of the authors is it's really about expectancy. The way this goes off the rails a bit is because after people recover and are back online, they have someone ask, well, how do you feel now? Fill out this depression survey. Then a week later, how do you feel now? And then a month later, how do you feel now? And after all of that, they're asked, well, what do you think you got? And naturally, the people who feel better said, well, I feel better, so I probably got ketamine, right? And the people who don't feel better said, no, I don't. I don't think that tells us necessarily about the mechanisms of ketamine, and certainly not about the mechanisms of psychedelics in this sense. More about, when people feel better, they think they got the active drug.
Okay. Other questions, Dr. Taylor?
Yeah, so those data are being very heavily collected and interrogated in the field right now, and you really can't, in good conscience, conduct a study at this point without asking those questions. But we're still waiting for some definitive responses there. Stay tuned. Yeah.
Dr. DiPaolo?
Great question. So if I understand, what's the utility of concurrent psychotherapy in any form, really? And that's also, that's a hotly debated topic in the field as well. There is a recent clinical trial with LSD administered to patients with anxiety that claimed that they had no psychotherapy, and that was a bit of a shocker. I have to say that I think that a lot of times we're playing with semantics here. I don't think there are really many or any trials that completely divest themselves of anything that looks like psychotherapy. But part of the problem that we struggle with in the center is, well, how do you define psychotherapy? And I think, not me, others, and I trust their opinion and their position, if you can define psychotherapy as something that is delivered by a trained therapist in the context of a therapeutic relationship with the intent to address something, then I think psychotherapy is occurring in most trials at some level, and I think it is important. And I think if you ask the patients, they'll indicate that as well.
Yeah, I just started seeing the word psychological support being used, which is meant to distinguish some of the supportive talk that's not maybe less classically psychotherapy. My own feeling is that you can't really make that distinction, that I think there's a therapeutic element to the supportive conversation by a trained person. We have time for one more question. Dr. McCabe.
I think there's a lot of truth in that. I think that we can get caught in parsing whether or not a positive experience is necessarily therapeutic, and I sometimes like to say that there are probably people who can get through this without having any support on the other end and without having much preparation, but I don't necessarily know who those people are going in. And sometimes people who you think will do well actually have, whether it's a lot of distress in the acute sense or a lot of distress in like the ontological sense after coming out of this experience. I think that there are people who could probably get through it without that, but I would be worried to not include therapeutic support as an option and an offering for all participants.
With that, we will wrap up and thank Dr. Barrett for a magnificent